Hi, this is Derek Mahoney, and I'm here to share with you some information about my PhD research. I've been doing this research for a number of years now, and it's through the University of Barcelona, one of the top Spanish universities, and a great place for me to research what I'm researching because the previous chairman there, Professor Van Duren-Arks, has been instrumental in introducing myofunctional therapy. So my PhD has looked at something different. I've looked at what effect orthodontic treatment can have on a child's airway, specifically those children who have what's called sleep-disordered breathing problems. There's been other papers that have only looked specifically at one type of sleep-disordered breathing problem, which is the dangerous one, obstructive sleep apnea. In our research, we've looked at everything from upper airway resistance syndrome, OSA, mouth breathing, to see what effect this may or may not have on the facial development and the development of the dentition / palate. I've collected data over the last 15 years for patients referred to me between the ages of 7 and 9. And I've picked the 7 to 9 age group because if you look at what the Orthodontic Society is recommending, specifically the American Orthodontic Society, they're suggesting when a child should first see an orthodontist. And they're explaining the benefits of that consultation occurring at 7. But most of the benefits they discuss are benefits associated with the bite, etc. What I'm talking about is benefits associated with breathing, with good sleep, and very good facial development. So what we did in our sample, all the children were initially given a Bears questionnaire, and from that questionnaire I was able to ascertain which children had signs and symptoms associated with sleep-disordered breathing. We then did a baseline sleep study on those children, and we found that there was a high correlation between the malocclusion and their obstructive sleep apneic index / their sleep-disordered breathing problems, etc., etc. So we then went further and we started different treatments. Some children had pure ear, nose and throat involvement. Other children had ear, nose and throat involvement followed by myofunctional therapy. Other children had ear, nose and throat treatment followed by dentofacial orthopedics. So I developed the upper jaw if needed to. I brought the maxilla forward if I needed to. I brought the mandible forward. So the orthopedic treatment was what the child needed, not necessarily static for the study. And then we did another follow-up sleep study. Early intervention from the ear, nose and throat doctor. They had the orthopedics with me. They then had what's called myofunctional therapy. In other words, they were taught how to learn how to breathe through their nose with their lips together, tongue in the right position. And those exercises really strengthens the muscles that maintain the airway that we've established. And we found with those patients the best results. Not only that, the long-term results for these patients is amazing. Those who kept doing their myofunctional therapy exercises ended up with less problems than those who just had immediate treatment and no follow-up. If you want to be introduced to the literature review that I've had to go through, it's very exhaustive. I'll be publishing that on this Facebook group. It's called Dr. Mahoney's PhD group. It's designed for people who are interested in the research. So what do I hope to publish from my research? A number of papers, because remember, I've looked at a number of factors. I've looked at facial changes, I've looked at hyoid bone position, I've looked at the sleep apnea index, I've looked at the depth of the palate and the width of the palate, I've looked at cephalometric variables such as mandibular plane angle, I've looked at degrees of crowding, we've looked at children who are bedwetters and what improvement it had on their bedwetting, we've looked at children who had ADHD, so there's a whole number of papers that will be published, and those papers will first appear on this PhD group. So what do I hope to answer? That I think I can offer the profession, because remember, a PhD has to be original research, which is going to help all my colleagues. So question number one, what is the appropriate criteria to define a pediatric sleep medicine patient? Is it an upper age limit? Is it based on a certain type of pattern that they have during their sleep, etc., etc.? Then we look at the diagnostic criteria and who is the appropriate clinician for that diagnosis of sleep-disordered breathing. Question number three, and this is dear to my heart, what is the dentist's role in the screening of these children? You know, dentists spend a lot more time looking at a kid's mouth than a medical doctor would. So the dentist, unfortunately, only looking at the teeth and the gums. I'm teaching dentists to look at the airway and ask certain questions on that child's sleep pattern. So to me, I definitely feel that the dentist is the gatekeeper of the airway for these children. Then we talk about the appropriate screening protocols, and that's based on the evidence-based literature. Big question, what's the best age for intervention, right? Is age an appropriate indicator to treat? And in that regard, for orthopedics, I'm talking about 7 to 9 because that's when we get maximum growth of our jaws. And we establish certain breathing patterns, etc. earlier than that. Next thing, what treatment options are available that have scientific basis? I'm covering all the literature associated with MFT, dentofacial orthopedics, ear, nose and throat, etc., etc.